I'd like to present to you innovations in plastic surgery. Plastic surgery is a relatively young specialism, but although it's been here for just over a century, it brought some important innovations to medical technology. The reason why this was developed was because there was an increasing number of patients, in particular soldiers, that got serious injuries during World War I. In World War I, this war was fought from the trenches, and these soldiers who were stationed in these trenches, they got injured, especially in their face. At that time, none of these surgical procedures had any opportunity to solve these problems. And it all started with a Dutch surgeon and dentist, Johannes Esser, who started designing new techniques to solve these difficult problems in the face. And he did anatomical studies based on how blood vessels run and which part of skin can you actually lift up and move to the side which is lost. So for instance, in the cheek there is abundant skin in most people. You can borrow that tissue and move it forward to reconstruct a missing eyelid. Then in World War II, again, there was a big development going on in plastic surgery. And this was mainly due to the severe burns that were sustained by pilots in aircraft crashes. And it was now Dr. McIndoe from England who developed extra techniques to solve these particular problems. And he even had an own hospital in which all these pilots stayed for sometimes many years as they underwent several surgeries to bring them back to society again. And they even started their own foundation called the Guinea Pigs Club, because they were quite aware of the fact that they had experimental surgery being performed on them. And they even wrote their own anthem, and in this they described flaps and skin grafts that were performed on them, but ended with the sentence, "We'd rather be drinking than fighting." But even today, plastic surgery can be considered war surgery, because in many sites around the world, people are still being victimized because of amputations of nose, ears, or limbs due to punishment for religious reasons. Then in the 1960s, a new problem came ahead. It was now possible to transpose skin tissue to solve smaller problems within the face and the entire body. But at this stage, it was not possible to move bone, and particularly bone in the skull and in the face. And it was Dr. Tessier, a French plastic surgeon, who saw many of these patients as depicted here, with congenital malformations of the face. As you can see here, it's a mother and two children, so it's a congenital condition. And they have several functional problems. To start off with the skull, their skull sutures fused too early, so the skull itself won't grow, while the brain inside wants to expand. So this causes rise of the brain pressure and may even cause blindness. Their orbits are way too shallow, so it can't protect the eyeballs and also may injure the eyes itself. The upper jaw does not grow forward and causes respiratory problems and may even cause death by these patients. So Dr. Tessier felt the need again to develop new techniques to solve these problems. And he went on studying dry skulls and even corpses. And when he finally had the techniques ready in his head, he needed to do it on patients for the very first time. And you can imagine that at that time, everybody considered this kind of surgery to be lethal. He went over to the neurosurgeon in his hospital, proposed his type of surgery, and the reply of his neurosurgeon was, "Pourquoi pas? Why not?" And they actually did it. And they started off with adults and later turned on to this kind of surgery in children. And it was a huge step in plastic surgery, because now we were able to mobilize orbits, upper jaws, and entire parts of the skull and bring them together, forward, upward, in all sorts of directions. And of course, this was a procedure done by trial and error, and it had major complications in the beginning, but it was a vast step forward. He presented his work on an international meeting, and at that time, there were only like 10 other people interested in this kind of surgery, because nobody dared doing this. But they were so convinced that they tried this back home, being trained by him. And in Holland, this was Professor van der Meulen, who brought this type of surgery to Rotterdam, the Erasmus University. He even made his own surgical procedure called the medial fasciotomy, which is depicted here. This is a procedure in which we can bring towards each other the two orbits, which are too widely apart, and at the same time bring the very narrow upper jaw outward, which alleviates the breathing disorders. So this was a procedure that took like 8 hours, and it was very extensive concerning blood loss in these young children that we performed it. Nowadays, we've adjusted these kind of techniques, and we now use distraction techniques. And we do the same procedure initially. So this girl underwent that same procedure. We cut her face in two halves, brought them together, but then put on these distractors, and that means that it's a metal device with screws sticking out of her skull, and the parents themselves turn these screws every day, 0.5 millimeter, and slowly you bring forward the entire skeleton. So this is the 3D CT scan, pre-op and post-op, in which you see the difference that we did on the skull of this 6-year-old. Of course, this is a major achievement, functionally speaking. We expanded the volume of her brain, so the elevated brain pressure was now turned to normal values. We deepened her orbit, protecting the eyes, and we advanced the upper jaw, which made her breathing more normal. But there's another aspect that's as important as these functional problems, and that's normalizing facial appearance. Most of these children have normal intellect, but are considered as mentally retarded by people they meet. And this is the change we could make. This is pre-op and post-op. We know from many studies that if you have a different look, people regard you as being retarded, and that really does you short. You have lesser chance of getting a good education, lesser chance of a good career, and lesser chance of finding a partner. And I think with this kind of surgery, we improve their chances in society. Then at the same time, in the 60s, another development was made by plastic surgeons. They discovered techniques to do microsurgery. And microsurgery means that under the microscope, we were able to reconnect blood vessels. And this was made possible by using the instruments that watchmakers used at that time, who were very delicate. And by being able to reconnect blood vessels, you can restore blood flow. And actually, this invention of microsurgery enabled general surgeons to perform donor transplantation. Because of this invention, we can now transplant hearts and kidneys from one person to the other. For plastic surgeons, this is mainly used for replantation of amputated parts, like fingers and hands. This is a very common injury, especially because people are all keen on doing some work at home involving saws, and we get this a lot. Of course, it's obvious that this is quite important for your hand function if it is able to be restored. But microsurgery today is one of the basic tools of plastic surgery, and we keep expanding the implications of this technique. For instance, what we do regularly now is reconstruct breasts. If a woman has a breast amputation because of breast cancer, we want to restore that breast. And we prefer to use her own tissue. And fortunately, many women have some excess. And the excess is mainly at the belly. And there is fat and skin that you can actually get rid of. And you take it out together with the matching blood vessels. This is a surgery that's, I tell it within 10 seconds, but this takes like 6 hours to perform this kind of surgery. So you take out the skin and the fat with the blood vessels from the abdomen, you transpose that, and reconnect the blood vessels to those near the chest, and you reshape the fat and skin into a breast. And this is the kind of result that we now can actually achieve with this procedure. And of course, we used to do this, and still do this, with silicone breast prosthesis, which can be a fine technique, but this is own tissue, feels soft, feels like a breast, has more the appearance of a natural breast. And this is a major improvement in quality of life for these women, as you can imagine. But now to the latest innovation, and this also concerns microsurgery. We are now able to do transplantations of entire faces. It's not only the skin, but it also contains the muscles, the innervation of the muscles, so the facial nerve, the vessels, of course, that you need to reconnect, but you can even take entire pieces of bone. Why did it take so long for us to start doing this kind of surgery? Because the first was done in 2005, and we invented microsurgery in the 60s. Well, the main reason is that skin tissue in particular has a very high risk of being rejected if you get it from a donor, from somebody else. This in contrast to like kidneys and heart, on which this risk is much more reduced. So that means that these patients get higher dosages of drugs that suppress your immune system. And they have a downside. These medications increase your risk of getting cancer in the long run. So of course, if you need a new heart, there's no debate. You need the medication and you'll be willing to accept this risk. But what about a new face? Is it worth the risk? So for years, nobody dared to do it. It was technically possible, but we didn't dare to. Medications got better, and now we did it. We did this procedure. And the lady on top is the very first done in France in 2005. And by now we have 12 cases all over the world that had these facial transplantations. But with solving the problem with the drug medication, many more items still remain. Ethical dilemmas. For instance, who's going to be a donor? It's not as if you have filled out your donor form now that you're going to be used as a facial transplant. You need extra approval for that. So that's a problem. But the main problem is, will this patient accept a new face? Because you will not be the same as you were before. You'll be a mixture. Depending on the amount of your own facial skeleton that remains, that will determine some of the features that are yours. But you'll get lips, noses, eyelids, and other features from the donor patient. So you'll be a mixture of yourself and the donor. And that's difficult to accept for many patients. For instance, the first lady on the top, she's still now speaking about the face instead of my face. And that really illustrates the difficulty with accepting a new look. Out of these 12 patients, 2 have died, actually. And that's because, again, of the medication, which suppresses your immune system and may cause very severe infections that cannot be controlled. So this is still highly experimental. So what do we really need? What kind of inventions do we need for the future? That's tissue engineering. It would be absolutely best if we were able to take a little piece of tissue from the patient, grow it in the lab, 3-dimensionally, involving all the tissues that were lost, like bone, skin, muscle, nerve, and vessels, and then put it back. That would take care of the entire problem of the immune suppression that would be needed, but we're still a long way ahead from that. In Australia, they've now managed to grow fat cells 3-dimensionally, and this could be applied as a new way of restoring breasts, but it's still way ahead of us before we will be able to do this. So, in conclusion, plastic surgery is an ongoing quest to restore form and function in the most optimal way that we can, to restore quality of life, and by that quality of life we mean participation in society. Thank you.